Good morning. I am Dr. Srinivasan RAJAN from KAPV Medical College, Trichy. A brief description of myself. I did my undergraduate from Tanjore Medical College and later on qualified my post-graduation in Anaesthesia at Kasturba Medical College. Worked as senior residency at CMC Vellore and followed by in JIPMA Pondicherry. I've been working as assistant professor in KAP Medical College since 2008. So with this particular brief description, we'll just switch over to the topic of neuromuscular monitoring in anesthesia. To know the basics, we'll be discussing about, in short, about the normal physiology, how a neuromuscular junction acts, what is the importance of it, and how does a muscle contract, and these effects of physiology. And then we'll go in for the neuromuscular monitoring proper and its importance in anesthesia. In short, a neuromuscular junction is nothing but a synapse between the motor neuron and the muscle fiber. So usually this particular neuromuscular junction is located on the surface of the muscle, wherein the axon terminals from the anterior horn come and intercept onto the surface of the muscle fiber, forming the neuromuscular junction. Dating back to the history, we could say that in 1958, Christie and Churchill-Davidson described the use of a nerve stimulator to monitor the neuromuscular blockade. However, it was not until the train of four pattern was identified and discovered that the stimulation of train of four was described in 1970 that such an equipment came into routine clinical use. We are well aware that a contraction of the muscle fibers occurs in response to a noxious stimuli, or it is going to be a purposeful act. For such things to happen, there has to be an electrical trigger which reaches through the nerves onto the muscle fibers, which in turn produces a contraction of the actin myosin filaments, producing a particular contraction of the muscles or a purposeful act. So this is being given in detail as, so what happens when you want to have a purposeful act? There is a nerve electrical signal which reaches onto the surface of the muscle fiber. These they synthesize the acetylcholine molecules which are being stored as vesicles at the end plate. Now, stimulation occurs onto the surface of the nerve. What happens because of this particular stimulation? There is mobilization and secretion of acetylcholine through these active zones. So what do you mean by the active zones? I'll show you by the description of the pictures over there later on. Now all that we need to know is these presynaptic and postsynaptic junctions. So presynaptic, there are acetylcholine molecules which are being stored in vesicles, and postsynaptic, you have got these receptors which receive these acetylcholine molecules and then go in for an actin myosin contraction, producing a voluntary act or a muscular contraction. So proceeding there, the acetylcholine receptors are located in the end plate of the muscles which respond to the effect of the acetylcholine as soon as it goes and reaches onto the receptors. These acetylcholine receptors, as I told you, are post-junctional. Now, once these acetylcholine receptors receive the acetylcholine molecules, there is an influx of sodium which in turn produces a depolarization of the muscle fibers, which in turn produces an excitatory potential, producing a contraction of the muscle fibers. Now, this contraction cannot be sustained for a longer period. So, how does this contraction come to an end? It is mainly because of the destruction by the acetylcholine esterase. Now this is a diagrammatic representation of the neuromuscular junction. This is a diagrammatic representation of the neuromuscular junction, wherein you can see the end of the nerve comes and touches onto the surface of the muscle fiber, forming the neuromuscular junction. So the important points that you need to look into it here is now the midline is supposed to be the prejunctional. So this is supposed to be the prejunctional area. Now this is the prejunctional area and this is the postjunctional area. And here you can see the clefts, something called as the active zones. So these active zones are called as mainly because much of the acetylcholine vesicles are being stored in abundant qualities. Similarly, the crests, these are the crests, and these crests contain more number of acetylcholine receptors when compared to these folds. So it is like a finger-like pattern wherein it is called as folds and crests, but the crests contain more number of acetylcholine receptors when compared to that of your folds. Now, why is it important? In the sense like, so whenever there is a stimulation, these acetylcholine vesicles, they release the acetylcholine molecules, they come and act on these post-junctional receptors, mainly on these particular crests. Now, going up onto the next slide. Much more refined. Now, this is something a repetition of what has been told. Whenever there is a nerve action potential, there is a sodium influx into the muscle fibers, producing a depolarization, which in turn produces a influx of calcium, leading to the release of acetylcholine molecules. So once the acetylcholine molecules are being released, it goes into the post-junctional receptors, wherein it acts on these acetylcholine receptors, producing a contraction of the actin-myosin filament, producing a contraction of the muscle fibers. Now, whenever you have an increase in the calcium ions, whenever say for example there is 2 times the calcium ions, there is a 16-fold rise in the quantal content of your excitatory potential, which returns to normal with the efflux of potassium. So, the electrolyte balance has to be the balanced amount in order to produce a normal contraction. Now, we are much more bothered about the post-junctional acetylcholine receptors. There are 3 different types of acetylcholine receptors. One is the junctional or the mature receptors, which are concentrating much more. There are extra-junctional receptors or the immature receptors, and the neuronal alpha or the 7-nicotinic receptors. So in short, if I am going to say, the junctional or the mature receptors are the receptors which we are going to much more concentrate as far as the neuromuscular blockade is concerned, and the next thing is going extra junctional receptors. Now these extra junctional receptors, the immature receptors, are found in abundant quantities, especially after exposure to burns and trauma, wherein the subunits are going to alter, and this produces an irreversible blockade. And next thing is the neuronal alpha 7 nicotinic receptors, which are much more found in the juvenile aspects. So how do they differ? The basic is the same. There are 2 alpha units and 1 beta unit and a gamma unit, and a epsilon subunits in case of mature receptors. Now the epsilon unit is being replaced by a gamma subunit in an immature receptors, whereas in a neonatal or a neuronal 7 nicotinic receptors contain 5 alpha subunits alone. They do not have the other type of subunits. The acetylcholine receptors are synthesized in the muscle cells, and they are anchored to the end plate membrane by a special 43 kD protein known as rhabsin. There are 5 subunit proteins, and as you can see, there are 2 alpha units, 1 beta units, and a epsilon unit are available over there. Now, in order to open up these channels, at least one particular acetylcholine molecule is needed to open up, which in turn produces the influx of the calcium and potassium channels. So these channels are usually being kept open until there is an efflux of potassium and the effect of the cholinesterase enzyme, which in turn promotes the closure of these channels. Now, one particular example I can give over here is the effect of the curare. Now, these curare molecules, they go and act on these receptors wherein this acetylcholine goes and acts in, preventing the closure of the receptors, thereby producing a prolongation of the muscle relaxant. Now, so how does this get reversed? That we will see later. It is mainly because once this curare gets metabolized by the pseudocholinesterase enzymes, now these receptors are being available for the acetylcholine come and act, and it produces a closure of your end plate. Repetition. There are 2 alpha units. The acetylcholine, the channels open. When 1 alpha unit, the non-depolarizing agent is being utilized, and antagonist is by acetylcholinesterase. So it cannot be completely being open for a longer time. So these acetylcholinesterase goes and acts over it, producing a neutralization of the previous effect. Now, what exactly does the neostigmine do it? So in the absence of, I cannot say it is an absence. So once the patient, the surgery is over, and once we need to reverse it, we use neostigmine. So the effect of this neostigmine is that it pours the acetylcholine everywhere and throws out the non-depolarizing muscle relaxants. Now, studies have shown that in 45% of the patients, they had residual curarization, or the train of 4 ratio was around less than 0.9 in the postoperative recovery room after a single intubating dose of the intermediary acting drugs as atracurium. In simple aspects, most of the patients, when we don't monitor the neuromuscular monitoring, what happens is we just, once a surgery is over, once a patient has got a spontaneous efforts, what we do is we just reverse them with neostigmine and glycopyrrolate, and once their head rising test is good and the grip reflex is good, we just shift them out. But after that, when you have monitored with the particular monitors, they had shown that the train of 4 can be still much more less in these particular cases, which produces other pulmonary complications, which we'll look into it. So the residual curarization has been noticed in around 42% of the patients to be around train of 4 ratio of less than 0.7 in the postoperative recovery room after the administration of Vicronia. So in short, the clinical judgment may not be always correct. Now, as I said, once the patient, you call it as fine, that he has got a spontaneous efforts, now you have reversed him, the patient is moving his limbs, he is able to phonate, you feel that the muscle contraction is good, the patient has got a good reflex, then even if he is going to have a mild sedation or he is going to have a mild amount of residual paralysis, why not leave them to have a minimal amount of residual palsy? So in that case, it is not fair enough. So what are the effects of minimal residual paralysis? Number one, there can be a decreased chemoreceptor sensitivity to hypoxia. There can be a functional impairment of the pharyngeal and the upper esophageal muscles, leading to the development of asphyxia, impaired ability to maintain the airway because of the laxity of the muscles, and an increased risk for the development of postoperative pulmonary complications. Why do we need to monitor? Clinical indications. Let's discuss one in each. Most of the patients who are undergoing major procedures are being subjected to prolonged infusion of neuromuscular blockades. So what happens over here is they need to have a low dose infusions. So at a particular time, say for example, the patient runs in for around 6 to 8 hours, or sometimes even plastic surgeries and other oncology surgeries going on for around 8 to 12 hours. So these infusions go in for a longer period, and you cannot expect them to recover all of a sudden within a short period of stoppage of the drug. So in such cases, our monitors are going to be really effective to maintain the degree of relaxation, at the same time to monitor what is the effect of the outcome of the or how far the patient has come out of your muscle relaxant at the end of the procedure. When the surgery or anesthesia is prolonged for reasons unknown, and you don't want to have an inadequate reversal, or in other words, you need to have a perfect reversal, especially in cases of severe respiratory disease or in case of morbid obesity, where you don't want to take any part of chances over there. Whenever there is a harm, maybe because of the reversal agent. Example, the patient may be having a pre-op tachyarrhythmia, they may be in a cardiac failure status, or in severe wheezing patients where you don't want to have an excess of the drug being administered. The other conditions like your liver or renal dysfunction, wherein the pharmacokinetics of your muscle relaxants may be altered, may be prolonged or may shorten, and neuromuscular disorders such as myasthenia gravis or Eaton-Lambert syndrome. So most of these that has been enumerated is only a few reasons, but for all practical purposes, especially in prolonged surgeries as well as in liver or renal dysfunction in these cases, it is always wise to monitor the neuromuscular monitoring before you could reverse and set them straight. The reliable methods of monitoring for a peripheral nerve stimulation is that you need to stimulate the peripheral nerve and look for the response. The commonest is that of the ulnar nerve that we usually do is, and then place a positive and an electrode onto the ulnar nerve and observe for the flexion of the adductor pollicis. Other, supposing the availability or you are not an access of the ulnar nerve, then always there's another alternative is going to be the facial nerve, wherein you place the electrodes as shown in the picture, the positive and the negative electrodes, and look for the contraction of the orbicularis oculi. You can see the contraction of the orbicularis oculi. The next thing, supposing if you don't have an access on to the upper part of the body, then you can always have the other one available is going to be the posterior tibial nerve, where you observe for the flexion of the great toe. Other than these, there are other sites that you can usually that can be utilized. Mainly, it's going to be the deep peroneal nerve and the tibial nerve stimulation. By tibial nerve stimulation, you look for the dorsiflexion, bad flexion of the palm of the of the foot, and then you can try to stimulate the deep peroneal nerve, wherein there is a plantar flexion of the there is a dorsiflexion of the great toe. Now, which are the muscles? So, in order to produce a effective muscle contraction, you should select a particular muscle. So, what are all the dictums that you need to accept? Now, one, it should have a motor element. That is, the nerve that innervates the muscle has to have a motor element. Next thing, it should be close to the skin for the nerve to be stimulated. And the contraction in the muscle or the group of muscles involved, which the nerve supplies, must be visible or accessible to the evoked response monitoring. Or in other words, in simple words, the nerve should supply a muscle which has got a motor element, and once it's stimulated, you should be able to visualize the response by producing a muscle contraction. Now, what's the other hope? So, this is mainly, see, what are we going to do by monitoring on the peripheral muscles? So, this gives a indirect correlation of the reversal of the drug, especially in the diaphragmatic as well as the larynx, because these muscles are 1.5 times to 1.75 times more resistant to these drugs. Say for example, so this graph shows how does the adductor pollicis and the diaphragmatic muscles vary with the dosage and the time response. Now, how much do you stimulate and when do you do it? A stimulation it's being measured by in terms of the current. We need to know what is the maximal current and what do you mean by a supramaximal current. Now, maximal current is that current that is needed to induce a depolarization onto the muscle fibers, that is, in all the fibers of the muscle in a nerve bundle. I'm repeating, a maximal current is a current that is required to induce depolarization in all the fibers of the muscle fibers in a nerve bundle. The supramaximal stimulus is 25% more, especially in under anesthetic effect. It has to be given at a 25% more than the depicted. The type of the stimulation should be monophasic. It should be rectangular. A stimulus of around 50 milliamperes usually be given for a short duration of 0.2 milliseconds and at a constant current of a resistance of 0 to 5 ohms. There have been different patterns that have been studied, and always do not use alternating current, always the direct current with the battery, and for the nerves to be stimulated always use a surface ECG electrodes. Now, the commonest ones that are available is going to be subcutaneous needle electrodes and the ball electrodes. So previously they had insertion of the needles which was traumatizing onto the nerves, and then came the ball electrodes wherein you have a surface stimulation. These are the ones which are available around 5 years back, but now we have got sophisticated equipments. Now the patterns of nerve stimulation that you are going to observe is going to be the The commonest is going to be the single twitch stimulation, and which forms the basis of your nerve monitor, your neuromuscular monitor. Next is going to be the train of force stimulation, a tetanic stimulation, post-tetanic count stimulation, and double burst stimulation. In what way does each differ will be looked into it. A single twitch stimulation, a single square wave is being applied, which is of a supramaximal stimulus and is being given at regular intervals. A single square wave of supramaximal stimulus is being given at regular intervals. Now, in order to respond to the supramaximal stimulus, a twitch occurs. A twitch response occurs, which is depressed only when the neuromuscular blocking agent occupies 75% of the postsynaptic nicotinic receptors. I am telling you, the twitch response to a nerve stimulus usually occurs, which can be depressed only when the neuromuscular blocking agent occupies more than 75% of the postsynaptic nicotinic receptors. Now, this twitch depression to be more than 90% to provide good conditions for abdominal surgery. So, when is this particular single twitch being useful? Mainly at the time of onset of block. You give a paralyzing agent, you want to see whether the patient is being totally paralyzed. So, you see how far or how long it takes for the twitch to become depressed. So, mainly it is during the time of onset of blockade. Now, here I can show you the different types of the patterns that has been recorded. Now, the first graph shows a person who has been sedated but who has not been administered a depolarizing or a non-depolarizing blockade. Okay, so here you can see all the twitch responses are of the equal amplitude and at regular intervals. Now, you give a non-depolarizing blockade. As I told you, the non-depolarizing blockade mainly acts by a competitive inhibition. And here, the initial response, supposing you start giving it and giving a non-depolarizing response. So, initially you can see the response is going to be of the same amplitude for some time, and over a period of time, that is 1, 2 and 3 minutes, what happens? There is a fading of the response, and after that it totally disappears. Whereas you compare it with your depolarizing blockade. The depolarizing blockade initially has of the twitch of the same response, but then over a period of time, within less than around 60 to 90 seconds or less than a minute, it totally disappears, only to reappear and get back to its original amplitude over a period of 3 to 5 minutes. So, in simple terms, the depolarizing blockade does not have any fading effect when compared to that of the non-depolarizing blockade. That is a major difference that you can see over here. The train of 4 stimulation. The train of 4 supramaximal twitch stimuli with a frequency of 2 Hz. I mean to say that the train of 4 is the administration of a supramaximal twitch stimuli with a frequency of 2 Hz, which means we give 4 stimuli separated by 0.5 seconds. 0.5 seconds, okay. Or in other words, it is 2 Hz for 2 seconds. I am repeating, 2 Hz for 2 seconds. Now, compare the first twitch with that of the fourth twitch. So, this is how we know what is the percentage of depression. So, this is a normal train of 4 when being given in a person who is not being totally paralyzed. Now, you have given a drug and you have observed the train of 4 of the fourth one is supposed to be the slowest when compared to the first twitch, which is around 0.2. Okay, now then after some time, say for example the patient is recovered and you administer you check for the muscle response after around 2 to 3 minutes, and the twitch response keeps on gradually increasing and the train of ratio is going to be 0.4. Still you are not very happy with it and you keep on waiting for some more time. Still the response increases and the train of 4 ratio increases to 0.7. Now once the patient has been totally reversed of the drug, then all the 4 responses are back towards its normal or beyond 90%. Repeat, the train of flow ratio, there is a non-depolarizer blockade, produces a fade in the initial phases, but during the time of recovery, you can see that slowly it improves from 20%, 40, 70 and gets back to its 90%. As I told you, the difference between the non-depolarizers and the depolarizers are the depolarizers usually does not produce any fade, but the height of the amplitude of all the four, as you can see here, succinyl choline after administration, the amplitude is initially the same and then it goes down, finally it disappears. But once the reactivation occurs, you get all the four twitches, but they are of the equal amplitude. Whereas when compared to the non-depolarizers, you can have the initial phases show it is going to be beyond 90% or all the four twitches of the same height. But once these non-depolarizers go and act onto the acetylcholine receptors, what happens? There is not much of space for the acetylcholine to come and act. So what happens? It produces a fading effect. So as you can see, the difference between T1 and T4 gradually goes down, reaching to a stage of less than 0.2. But at the same time, you can observe once the drug has been metabolized and the patient is coming out of the muscle relaxant or after the administration of the neostigmine effect, you can see the first twitch appears, following which over a period of time the second twitch also does appear, then followed by the third and the fourth. But all the four are not of the same amplitude during the initial phases. So it takes around 3 to 7 minutes for the amplitude of the fourth one to reach to its peak effect, provided there is no other inhibitory factor preventing the reversal of the drug. Now we should know what is the difference between train of 4 versus the single twitch. I told you the T4 disappears at about 75% depression of T1, or in other words, at least 75% of the receptors has to be occupied by your non-depolarizing agent. The T3, the third twitch usually disappears when around 80 to 85% of the receptors are being occupied by your non-depolarizers, and when the second twitch is being disappearing, it shows around the patient is being depressed by more than 90% of the receptors are being occupied by a drug. There is a difference between the train of 4 count and the train of 4 ratio. Both of them need to be observed before you come up for a final diagnosis. What is the relationship between clinical and the train of 4 evoked stimulation? Usually what we do is you have a 5 seconds head raising test or leg lifting test, gripping of your hand grip reflex, the mesenteric reflexes. But here, when you have observed over here, your 5 second head lifting test or the leg lifting test, even when the train of 4 ratio is around 0.6, you can achieve these factors. And when the train of 4 is around 0.7%, you can have a normal grip reflex. But these mesenteric reflexes usually take around a train of 4 equivalent of 0.86. So why do you need these? We'll be looking into it. And all these subjects, they are usually uncomfortable when the train of 4 is less than 0.75. Though they seem to come out of the muscle relaxants, still when the train of 4 is less than 0.75, they do have some amount of a discomfort. Now studies show, I'm not going into much of the details over here, most of the studies show that there is a reduction in the vital capacity, the negative inspiratory force and the peak expiratory flow rate as the train of ratio is low, and as the train of flow ratio increases, the vital capacity, the negative inspiratory force as well as the peak expiratory flow rate have seen to be improving. You can see with a minimal train of flow ratio of 0.8, the vital capacity has improved from 91 to 99%, the negative inspiratory force of 70% has improved to 87%, and the peak expiratory flow rate from 95% it has come up to 94%. Not going into it. Now, next we'll go to the double burst stimulation. A double burst stimulation is nothing but it is a manual detection of a subtle degree of neuromuscular blockade without the use of a recording devices. So this was the initial that is being used in two short bursts of 50 Hz separated by 70 milliseconds. A series of 3 and 2 impulses, or a 3 and 3 impulses. There are two different types, DBS 3 and 2 and DBS 3 and 3 that are available. So D2 by D1 ratio usually shows a fade on application of a non-depolarizing muscle relaxant. A fade is more easily detected manually with DBS than in cases of train of 4. So a train of 4 of 0.4 or less, but a DBS of 0.6 is detectable. So when does your double burst stimulation be helpful? In two different aspects. Number one, supposing if you are undergoing a neurosurgery or an ophthalmic surgery wherein you don't want to have the minimal amount of a cough reflex or a minimal amount of a bucking over that. In those patients, you should keep the train of 4 as 0. But even then in ophthalmic surgery or neurosurgery, even the minimal stimulation can be a botheration. So in that case, you should increase the dosage in such that the double burst stimulation is also being absent. Now this is for the total relaxation. Now when you are going to reverse, in what way does your double burst stimulation help you? Now this particular double burst stimulation, supposing at the time of the end of the surgery, your train of 4 is 0 for a long time, or there is no response or no twitch response. You wait for the double burst stimulation to be activated. At that particular time, when you have the first twitch or the first response, that shows the patient is recovering from your neuromuscular blockade. All that you need to do is wait until the patient is going to have your first twitch of your train of 4. This is the depiction of how it comes over there. So how you are going to correlate with your train of 4? As long as the train of 4 is going to be 0.9, your double burst is also going to be the same. Now, say for example, you consider for your recovery pattern. So when the train of 4 is only 0.2, you can see the first recovery of your double burst stimulation has the full amplitude and the other one is going to be low. And as time goes on, what will happen is the amplitude keeps increasing with your timing. Tetanic stimulation. The tetanic stimulation is application of a high frequency, that is around 50 to 200 Hz stimulus for a set time. So this particular 50 to 200 Hz is normally being given for a duration of around 5 seconds. In a healthy skeletal muscle movement, the response is maintained as a tetanic contraction. Now usually the tetanic stimulation is quite painful and please avoid in case of conscious patients. And you are not supposed to be reproduced in less than 6 to 10 minutes. So once you have applied a tetanic stimulation, do not repeat it in less than 6 to 10 minutes. Whereas a train of 4 can be repeated in less than 10 seconds. So this is the difference we need. So when do you apply a tetanic stimulation? We'll look into it. So what do you call as a fade? When the margin of safety, I am repeating, when the margin of safety at the postsynaptic membrane, that is the number of free cholinergic receptors, is reduced by the non-depolarizing neuromuscular blocking drugs, a typical reduction in the twitch height is seen with a fade during, for instance, repeated stimulation. So if I am not confusing, what I mean to say is, supposing if there are 40 post-junctional receptors, for example, which are available and which has to be occupied by the acetylcholine molecules in order to produce a firm contraction. Say your neuromuscular blocking drugs goes and occupies around 30 to 35 receptors and only 5 receptors are available. Then following a stimulus, the 5 receptors that are available is being acted upon by the acetylcholine molecules, but that does not produce a effective muscle contraction beyond a single twitch. So that is the margin of safety. Now this is a repetition of the same. Post-tetanic count. Can we gauge the neuromuscular blockade if the train of 4 is absent? One I said is going to be a double burst technique. Next thing is going to be your post-tetanic count. So what we can do over here is you subject the muscle to go in for a tetanus. You apply a 50 Hz tetanic stimulation, apply it for 5 seconds. followed by a 1 Hz supramaximal single stimuli after a gap of 3 seconds. Now you start over here. So these particular counts, they keep on increasing over a period of time. So when is it going to be useful? Supposing you're given a drug, train of 4 is 0. So you want to know whether the patient is going to really come out. You give a tetanic stimuli, which in turn releases off all the acetylcholine molecules. Then in case the patient is going to come out, the newer acetylcholine molecules keep forming around. You keep stimulating the nerve stimulation. So what happens over here is whatever is going to be the residual acetylcholine, if it is available, goes and acts on the peripheral receptors, which in turn produce a twitch response. If in turn, if there is no acetylcholine molecules available, nothing will be seen over here. Here again, you can see there is going to be a fade in the response over a period of time. This count is usually counted for up to 20 numbers. So as long as the count is going to keep on increasing, supposing the patient is coming out of the muscle relaxant and you want to verify whether what is the correct time to give for your reversal dosage. Wait and wait until your train of 4 comes up to at least 2 twitches and at least your post-tetanic count increases beyond 10. So initially if the post-tetanic count is going to be 0, do not try to reverse the patient. When the post-tetanic count increases to more than 10 but still there is a fade, do not try to reverse the patient. But if the post-tetanic count exceeds more than 15 to 20 but still there is a minimal amount of fade, you can attempt to go in for a reversal. Post-tetanic potentiation and post-tetanic count. Now, tetanic stimulation facilitates the mobilization of acetylcholine from the reserve pools, that is the reserve pools from the end plate, to the immediate stores and increases the synthesis of the acetylcholine. Now, this enhanced synthesis and mobilization of the acetylcholine explains the phenomena of post-tetanic potentiation. Now, I think I have given the answer for your post-tetanic count too. Now, the use of post-tetanic count. The main use of post-tetanic count is when there is a profound neuromuscular blockade. For example, during retinal surgery, when the movement or coughing could have been devastating effects, always to have a post-tetanic count of 0. Now, when and what to use? During the time of onset of your neuromuscular blockade, always use a single twitch stimulus so that you can observe when the twitch is going to disappear. When you need an intense blockade, check for your post-tetanic count to be 0. When you need a surgical relaxation, try to keep your train of 4 to less than 2. And for your recovery purposes, the gold standard is the train of 4, that is, do not reverse, or in other words, be confident to reverse once you have got a train of 4 of more than 2 or 3. Assessment of the responses. There are different ways of assessment. One is visual and tactile. Mechanomyography, that is usually being done over here with the machines available. Electromyography, acceleromyography, and others. Now we'll just see what are all the assessment responses are being available, or the recording devices that is available. Now first and foremost is going to be the mechanomyography, which measures the isometric contraction of the muscle after the stimulation of the corresponding nerve. This usually, the picture depicts the ulnar nerve that is being stimulated and the adductor pollicis tendon is being subject to contraction, and this in turn is being monitored. Electromyography, here the muscle action potential in response to nerve stimulation is being seen. That is, you stimulate the nerve and look for the muscle action potential. The commonest nerve that is being selected is going to be the ulnar nerve or the median nerve. The electromyography from either the thenar or the hypothenar or the first dorsal interosseous muscle is usually being selected, and the results are amplified, rectified and integrated into a recording machine, and the results are given as a percentage of control, or in direct words it is a train of 4 ratio. The newer sites, I have not used it, but still as per the text it is the larynx and the diaphragm. Now what are the limitations of using the electromyography? One is the major is going to be the improper electrode placement. So please do place your electrodes onto the directly either above the nerves or the above the nerve, or if you are using needle electrodes, it has to be onto the nerves. The other limitations include direct muscle stimulation. That is, you may not be on to the nerve fiber, but you would have applied your electrical stimulation directly onto the muscle, creating a stimulation. Electrical interference, that is, whenever the patient is undergoing a surgery, there can be a diathermy interference over there which can interfere with your train of force stimulation, and there is no return to the control value. Now this is the electromyography that is being used, where you have different types of electrodes, and you can measure from your thenar and hypothenar muscles also. Electromyography is a recording of a component of the action potential that occurs during the muscle contraction, whether it is going to be voluntary or it is going to be evoked. Now the commonest that we are being used over here is going to be our acceleromyography, wherein it follows the Newton's second law, wherein force is equal to mass into acceleration. So what it does over here is the isotonic acceleration of the stimulated muscle in response to a nerve stimulation. So for example, you are stimulating the ulnar nerve, it produces the adductor pollicis contraction. So this particular contraction over a period of sensors, it's being amplitude and gives you a response onto the digital screen. Now the SimPod is the newer machine that is being available nowadays, and hospital has a few numbers. We have got around 6 numbers of this particular unit. Though it's supposed to be costly, it is really effective for us, and you can see the graph that is being given over here. So the top column which measures is going to be the 45 MA, but 45 MA is the current that is being given over here. The 4 strands that you can see over here is the train of 4. 1, 2, 3 and 4, you can see there is a fading which shows there is a 31% recovery or a 31% blockade over there, whichever it is. It depends upon which time you are going to apply. So these are the screen displays that usually is being seen. For completion's sake, I can say the other things that are available are the kinemyography, the cuff pressure modality, the compressormyography and the phonomyography, which I am not going to go into the details. There's a repetition of your depolarizing and non-depolarizing agents. Now, what are the effects of your residual paralysis? I'm going to compare the train of 4 ratio along with the signs of symptoms. Now, when the train of 4 ratio is going to be around 0.7 to 0.75, the signs and symptoms that has been observed are going to be diplopia and visual disturbances, decreased in the hand grip strength, inability to maintain the incisor teeth opposition. A tongue depressor test is usually being found to be negative. There is an inability to sit up without assistance. There is a severe facial weakness. Speaking has got a major effort. That is, the patient has to take extra efforts to speak, and there is a overall weakness and tiredness. Supposing if you are given certain reversal agents and the train of ratio has improved to 0.5 and to 0.9, then all other symptoms disappear, but still there can be a diplopia and visual disturbances and generalized fatigue. Different scenarios. Always monitor hemiplegic patients on the unaffected side and not on the paralytic side. Paraplegia is always a question, and try to use the facial nerve stimulation. Quadriplegia, still again it's going to be a problem, and the same occurs in case of Parkinson's and Duchenne. Speaking about all the advantages of neuromuscular monitoring, there should be a few deficiencies in these monitors. Now, a few of them can be enumerated. Number one is going to be the neuromuscular responses may appear normal despite the persistence of a receptor occupancy by the non-depolarizing muscle relaxants. The T4 to T1 ratio is seen to be 1 even when there is a 40 to 50% receptors are still occupied by these non-depolarizers. The patient may have weakness even at a train of 4 ratio as high as 0.8 to 0.9. An adequate recovery do not usually guarantee that a ventilatory function or airway is being protected, and hypothermia limits the interpretation of the responses. Neuromuscular junction monitoring. In a summary, we have just seen what are all the indications for using the neuromuscular monitors, what are the current trends, the nerves and the places you are supposed to stimulate and observe, the types of stimulation that are available, what do you mean by a post-tetanic count, and the devices to record. The future of neuromuscular blocking agents or the reversal, what is it going to be? Either it's going to be anticholinesterases or sugammadex. We'll try to discuss in our next topic. Thank you.